So hello, everybody, and thank you again for joining us this evening. Today we have, I think, a very interesting talk by Rick Nelson to talk about spontaneous management of spontaneous CSF leak. Hi, Rick, can you hear me?
Yes, I can hear you. Thank you.
That's great. Thank you very much for taking the time to join us this morning.
Of course. Thank you for having me.
It's in the afternoon here, so this is the end of the day for us. So please go ahead, you have the podium. Please go ahead and, we could start sharing the...
Yeah, I'll share my screen here. Let's see, where's the button? There we go. Can everyone see that?
Yes, absolutely. Thank you.
So this is a talk I've given several times, and this is an area of interest of mine clinically. And I've, as you can see from the title, I've sort of coined this term, the American obesolique epidemic. And many of you probably know something about CSF leaks, but it's highly associated with obesity, and we'll talk about that. And Americans, and maybe even people around the world, have a problem with obesity. And so we'll talk about the pathophysiology and the treatment. So this is my standard slide to say that I don't have any financial disclosures from this talk. So spontaneous CSF leaks have sort of two requirements. They require the bone of the skull base to have a defect. In addition, the patient also has to have a defect in the dura, which lines the brain, to actually have the spinal fluid leak out. If there's a defect in the bone, sometimes people have an encephalocelia where the brain herniates into the pneumatized space, but isn't not actively leaking. And for temporal bone CSF leaks, there's been many studies about the repair, whether it's a middle cranial fossa or MCF approach, a transmastoid approach, or even a combined transmastoid middle fossa approach. And this is a schematic just showing how the Tegman tympani over the middle ear can be repaired with a multi-layer closure. And I'll show you a video of that later on. So CSF leaks can happen both in the anterior skull base and the lateral skull base, and they happen over pneumatized spaces. So these happen over the anterior nasal sinuses, and then over the ear, they can happen over the mastoid and also over the middle ear. And you can see this bone, the Tegman bone, is very, very thin. And we've measured it, tried to measure it. And our best estimate is between 0.6 and 0.8 millimeters in thickness. So not too much erosion of that bone can lead to a spinal fluid leak. And so these are differentiated from non-spontaneous leaks because non-spontaneous obviously are those that could result from some inciting event like a trauma, a surgery like an acoustic neuroma surgery, or even a congenital situation. But spontaneous, as far as we can tell, has no inciting event. So that's why we term them this way. And so the diagnosis, as you may or may not kind of realize in your clinical practice, the diagnosis is not straightforward. There's often some gray area, and often people are delayed in getting to the diagnosis and getting to treatment. So you have to have a high index of suspicion when you're seeing these patients and looking in their ear. Many of these patients don't have any ear history at all. And they may have a history of meningitis that sort of just went, they got diagnosed and never really looked at the ear, and all of a sudden people realize that they have an ear effusion. There was actually CSF. They may have clear rhinorrhea that gets misdiagnosed as allergies or rhinitis. And often these patients are obese. So on exam, you often see clear fluid in the middle ear, or if you put a pressure equalizing tube in, the fluid will just pour out and it will not stop. It won't respond to ototopical medications. So this is a video I've took of a patient of mine that just shows you how the patient has a CSF leak through this PE tube. And you can see instantly that ear canal is all macerated from this chronic CSF coming out of their ear. And so you can see the clear fluid coming out, and there's a little pulsation to it. And then when I have the patient bear down and Valsalva, the fluid comes even faster. So that's a pretty typical sign when somebody has an ear tube in, is Valsalva will make it, increasing the intracranial pressure will make it pour out even more. And then the next best step in diagnosis is to get a coronal CT scan, high resolution scan, and evaluate the tegmen. And you can see this patient has a gigantic tegmen tympani defect, and the malleus is essentially sitting in the temporal lobe. And you can also do MRIs. It's not totally a standard of practice for me, but you can get an MRI to look for an encephalocele. But the first step is a CT scan. So I've sort of come up with this algorithm. Now, this is an algorithm that I think works for most patients. We recently published it in Laryngoscope. This is obviously not a, tried and true, but it's what I follow. And so it starts at the top with persistent middle ear fluid. And so if it's clear or it's pulsating from a tube that you've put in, the next step is to get a CT. And if the defect in the tegmen is bigger than 3 millimeters, that's worrisome. And we've measured all of our defects, and the average is about 4 to 5 millimeters. So 3 is a good cutoff. And I would say that if the patient's obese, BMI is over 30, and they're middle-aged, and they have a tegmen defect and clear fluid, I diagnose them with a spontaneous leak, and that's enough for me. Now, not everybody is so straightforward. Some patients may not be obese, so we get an MRI to look for an encephalocele or other causes. I've seen what seems to be a unilateral effusion, and there is a eustachian tube obstruction from a mass or from skull base osteomyelitis. So those can be found on MRI. Now, if there's only fluid on the MRI and no encephalocele, then you need to, and you're not definitive about it, then you need to put an ear tube in and see if you can collect the fluid. And many patients have trouble collecting enough fluid. Nowadays, we can usually sample less than a milliliter or a microliter to, a few microliters to actually get the diagnosis, but some people just can't collect enough. So then we move towards a cisternogram. And here we do a combined CT and MRI cisternogram. So what we do is we place intrathecal contrast for both the CT and MRI at the same time. And we have basically let the patient move around so the CSF space gets circulated with the contrast. And then you can see on this example here, this patient had no major defect except there's one over the intra-auditory canal. And this is the contrast in the spinal fluid space on the MRI cisternogram that's leaking directly into the middle ear. And so this is a very unusual location for this leak that we diagnosed with a cisternogram. So that's the sort of algorithm that I followed to come up with the diagnosis. So I mentioned before that many of these patients are obese. And so we know there's a big correlation between obesity and spontaneous CSF leaks. And there's been many, many papers published on this association, as you can see here, including our own cohorts here in Indiana. And many of you probably know about the United States obesity epidemic, but you may not have seen these in graphical demonstration. And so these next series of images are from the Centers for Disease Control, CDC, at the United States. And before I show you that, I just want to tell you that obesity in the United States is a major problem. And in 2008, it was estimated that we spent $147 billion on obesity-related diseases in medical care. So this is a huge expense for the United States. So these are color-coded by state. So this is the United States, and so Indiana, where I am, is right here. And so you can see this is in 1985. And our rates of obesity. This means a BMI greater than or equal to 30. So you can see the heaviest states their rate of obesity was still only 10 to 14%. And you can see every year how this changes, just with the colors. So this is 1990. $1995. Now, Indiana and other states are over 20% obesity, and it's still not 2000 yet. Now, some are over 25%. Now, some are over 30% in 2005. So this is 2010. So there's many states that have an obesity rate of over 30% of the population. So this is a recent this is an article in the JAMA that talked about the rate of obesity, and this was back in 2012. So they're estimating what would happen to the United States in 2030. What would the obesity rate be? And they estimated that 44% of the population would have an obesity rate greater than 30. So the CDC still monitored this, and they changed the colors a little bit, but you can see that this is in 2010. The colors are a little changed, but you can see that over time, the rate continues to get higher and higher. And obviously, there's lots of different factors on why Americans continue to get obese. The food we eat, the lack of exercise, sitting around watching TV, and not exercising at all. So these are major issues in the United States. And so I graphically demonstrated and extrapolated the obesity rate in the United States. And you can see in the 80s, this inflection point. Our obesity rate was pretty stable, and then it's just continued to rise over time. Now our estimated percent of our population is upper 30% of us are obese. And so that kind of wonders what happens with the spontaneous leaks? Are we seeing more of those? And so I screened a national database in the United States that encompasses most of the academic centers. And when you look at all centers that were reporting between 2002 and 2012, and you look for the surgical codes for spontaneous leak repair, the numbers went from 218 to 488. So it doubled, more than doubled in 10 years, the number of CSF leaks that were repaired. And at that same time, the non-spontaneous leaks, there was no change. So there's clearly a rise in the number of these leaks that we're seeing. And that was up till 2012. And I would tell you that even from 2012, we continue to see a larger and larger percentage of our clinic patients have spontaneous leaks. And so when we were doing this study, we also wanted to see, well, if the obesity rate in the United States, as you can see, is pretty high in the South and not so high in the West. And so we looked at the rates of leak rates based on region. And you can see the West has a low obesity rate and a low rate of craniotomy for CSF leaks, whereas the Midwest and the South, which are the heaviest regions by obesity rate, have the highest rate of leak repairs. So this all makes sense that it's highly correlated with obesity. So this is how I came up with the term obesaleak epidemic in the United States. So now we'll move to surgical repair. And as I mentioned, the reason we want to repair these is one, people have hearing loss. They have fluid in their ear that's draining out of their ear. And then most critically is meningitis and infection. So about 15 to 20% of my patients will come to me with a history of meningitis. And just to give you an example, I had a patient who got transferred in while I was on call, and she had bilateral CSF leaks that were undiagnosed. And she was intubated in the ICU in a coma because of meningitis. and she recovered and came into clinic, and we ultimately repaired both sides, and she did great. But this is how problematic this can be if it's not treated. So the middle cranial fossa approach is what I use exclusively. Some advocate for a transmastoid approach from below, and some do a combined approach. My feeling is that the middle fossa approach has several advantages. One is that you can see the entire floor and tegmen from above. And most of the patients that I treat don't just have one defect in the bone. They usually have multiple defects. And so if you're repairing it from below, you may miss a defect. And the anterior defects around the middle ear and the ossicles are more difficult to repair from below and much easier to repair from above. And also there's the pressure from the temporal lobe pushing on your repair. And so repairing it from above allows you that to not have to fight those forces from below. There's a discussion about the risk of a craniotomy and the possible downsides of that. And I'll show you our data, but it's a very safe approach. It's all extradural, but it's a very safe approach. So this is a schematic showing how you have a craniotomy here. You're looking down into the middle ear. You can actually see the malleus and the incus through the bone defects of the tegmen tympani. And this is an intraoperative example of several different defects in the bone. There's a couple back here and one up here, how there's multiple defects throughout the skull base. So this is a video, and
this is the MCF
let me turn my
during
volume down.
spontaneous.
And so I had this patient, she was 40 years old, and she got referred to me for cholesteatoma. You can already see on the scan that the ossicles are intact, but there's a huge tegmen defect and fluid or soft tissue in the middle ear. And her BMI was 51. On MRI, you can see this encephalocele. And you can also see she has an empty cella, which is consistent with elevated intracranial hypertension. So this is a terional incision in the scalp. And for females, they just shave right along the incision and leave this tuft of hair. So they basically, no one knows that they've had surgery after they're finished. And then we drill a 4.5 by 4.5 centimeter craniotomy with an otologic burr. And let me orient you here. So this is anterior. This is posterior. I'm sitting at the head of the bed, so I'm looking towards the feet. So the top of the auricle and ear are down here. And this is the temporal lobe. And so this is the inferior aspect of the craniotomy site. And we're going to take that inner table down so we can see the floor over the temporal bone. And so again, to the right is posterior and to the left is anterior. And it's always good to elevate the temporal lobe from posterior to anterior because the greater superficial petrosal portion of the facial nerve runs posterior to anterior. So here's the petrous ridge, right over the mastoid area of the middle ear. And this is the encephalocele we're starting to see here. Other things you want to watch out for is a concomitant superior semicircular canal dehiscence. And that should be able to be diagnosed on your preoperative CT scan. If that's present, you want to take extra care not to have suction around that area and then repair via occlusion the superior canal defect. So this is the encephalocele. And when you look pathologically at the brain, that's the encephalocele, it has a lot of gliosis. And so we just transect that portion of the encephalocele. Here we're using a stimulator to show the greater superficial petrosal nerve. And now we're going to place what's called a house urban middle fossa retractor. And this slots on each side of the craniotomy, and then it has a blade that sits down on the petrous ridge. So here you can see the GSPN nerve and the geniculate. The internal auditory canal would be down here. This is the arcuate eminence where the superior semicircular canal would be. Mastoid is here. And then middle ear is here. So you can see this large encephalocele that we'll take out. So things we need to watch out for are obviously the ossicles and the facial nerve. And so we gently free up the encephalocele. And again, sometimes you have to make the defect a little larger to get the encephalocele out, but ultimately you're going to repair it anyway. That's a pretty large encephalocele. And now we have the bone defect that we'll repair with a split calvarial bone graft. So the craniotomy bone, the inner table, we can fillet and take a little piece of that bone. And then what I do is I make hydroxyapatite bone cement. And I mix the powder and the liquid together by myself and make it kind of a little thicker than the typical applicator would make. And I seal the entire bone chip on the outside so that none of the bone cement leaks into the middle ear. So once we have the bone chip in place, then I pretty much coat the rest of the entire skull base with a layer of the bone cement. And that's the final appearance of the bone cement. You can see after about 8 minutes, it hardens, and how hard that is by just touching it with a freer. And then we repair the dura with an extradural multi-layer closure. And this is dura repair. It's nice because it's very pliable. We place that first. And then I use temporalis fascia that I've harvested on my approach from the temporalis muscle. And then just to make sure that there's no active leak while we're closing, we find the dural defect. And then we place what's called Duragen, which is a sponge type material based on collagen, over that defect. And so there's no fluid accumulating during the closure. We plate the craniotomy site with absorbable plates, so they'll dissolve in 9 to 12 months. And then we do a multi-layer closure and some skin glue. And this is an example of the preoperative CT scan with a Tegman defect and the fluid in the ear. And this is after the bone cement reconstruction. And you can see that the bone cement looks like bone on the CT scan. And so we've evaluated several outcomes with our patients, one of them being hearing outcomes. And so this is the American Academy of Otolaryngology's recommended scattergram for hearing results. And so what this shows, it looks very busy, but it's quite simple. So pure tone average is on the left. So if the patient improves in their pure tone average, they will go this direction, up in this quadrant, by this many decibels. And then word understanding, word discrimination, if it improves, it goes in this direction. Obviously, if it gets worse, it goes in the other quadrants. So you can see that all but one patient improved in their hearing outcomes. And in fact, this patient just went from 76% discrimination to 74% discrimination, but his pure tone average actually improved. So this is a very good result for the hearing. And it also tells you that the CSF leak is resolved, because if the hearing doesn't improve, then it makes you wonder if the fluid actually got fixed in the ear. So recently, we just had our series accepted in laryngoscope. And these are all of my patients that I've done in the last 5 years. All had temporal bone CSF leaks. As you can see, there are 38 patients, and several of them had bilateral CSF leaks, so that was a total of 45 cases. Typical with other reports, our average age was around 55, so middle age. And in fact, this is an important factor too, is that 11 of my patients were over the age of 65. A lot of people have some trepidation about doing a craniotomy on somebody that's over the age of 65. And in fact, it seems quite safe to do that even if they're older. And then the BMI, essentially all of the patients were obese, and the average BMI was 38. And 6 of the 38 patients had a history of meningitis before they came to see me. So early in my sort of series, I was repairing these with a multi-layer closure without bone cement. And then I moved to exclusively using the bone cement reconstruction that you saw in the video. And so of the patients that did not have bone cement, one patient had post-op otorrhea that required a lumbar drain and it sealed. Another patient had post-operative rhinorrhea that resolved without treatment in 3 weeks. And we confirmed that with the CT showing there's no fluid in the ear. But the length of stay was about 3.5 days for these patients. And the bone cement, there were no post-operative leaks, and the length of stay was 1 day shorter on average. And looking at all patients, we had no infections or meningitis, no seizures, intracranial complications, but 2 patients had transient aphasia, meaning they had some word finding difficulty that resolved within a week with post-operative steroids. There was no long-term aphasia issues. So to me, this shows that it's a very safe procedure. In long term, we've had no patients that have had a re-leak, although our follow-up, as you can see, was from 2014 to 2019, is not decades long. So that obviously will be need to follow that long term. So let's talk about what we think is causing these leaks. We know there's a high correlation between obesity and spinal fluid leaks, but is this really the cause? And one thing I found that I think is very helpful in our understanding of the pathophysiology is when I was doing my fellowship at the University of Iowa, we did a lot of craniotomies, not only for CSF leaks, but also for patients with small vestibular schwannomas. And when I would drill the craniotomy, I noticed that the patients with CSF leaks had very thin skulls compared to the patients with vestibular schwannomas. And so I wanted to see if that was objectively able to be determined. So we set up a study and to look at the actual skull, not just the skull base, but the calvarium of the patient. And so our question was, is the CSF leak patients have thinner skulls on CT images? And also, do all obese patients have thin skulls? And so you can see this is an example of a patient with a high resolution CT, which shows the calvarium squamous portion of the temporal bone. And this is a CSF leak patient, which shows it's quite thinner. So we came up with a measuring algorithm in the Department of Radiology where we can highlight just the Hounsfield units of the skull and very accurately measure volumes of the skull. And in our same image of the patient, the nice thing is that they have an internal control that we can control for bone problems such as osteoporosis by measuring their zygoma. So the cheekbone, the zygoma, we also measured to make sure that whether it was, if we did see thinning, was it actually osteoporosis or was it a skull problem? And so we measured both the calvarium and the zygoma. And we had a couple different control groups. One was an obese control group that had cochlear implants. And then we had a non-obese cochlear implant control group. And what you can see from this graph is that when we measured the squamous temporal bone, the thickness of the cochlear implant patients that were normal weight versus the obese cochlear implant controls were exactly the same. But the spinal fluid leak patients had 22% thinner skulls than the other two control groups. And the zygoma was exactly the same across the three groups. And this tells us that a couple things. One, that the obesity is not the only cause. And two, it's an intracranial problem and not a systemic bone absorption problem. So as I mentioned, we know obesity is associated with CSF leaks, but they have this isolated skull thinning. So we know there's skull thinning on their way to having a CSF leak. And we can use skull thickness as a proxy for the tegmen bone, because the tegmen bone, as I mentioned, is very difficult to measure. So we can actually measure the skull as kind of a proxy for that. And so if it's an intracranial problem, is it a pressure issue? So we wanted to look at what intracranial pressure conditions may lead to skull thinning. And there's two that we in the literature have been shown to cause intracranial hypertension. The first being obstructive sleep apnea. And we know that CSF leaks are associated with obesity, and obesity is associated with sleep apnea. And we know that sleep apnea is associated with elevated intracranial pressure during apneic episodes. And I'll show you, this is data back in 1989 where they showed that large spikes in intracranial pressure occur every time there's an apneic event. So if a patient stops breathing, intracranial pressure spikes, and then they gasp for air and the pressure goes back down. So this cyclical intracranial pressure problem has been seen in obstructive sleep apnea patients. So we hypothesize that maybe sleep apnea could be a cause. And then we know that there's idiopathic intracranial hypertension, which is a chronically elevated pressure issue. So we wanted to see if those two conditions, which we know are associated with obesity, would independently thin the skull and lead to CSF leaks. So the first thing we did was we wanted to see, well, what's the proportion or incidence of sleep apnea in our CSF leak patients that we see coming into clinic? So I set up a prospective study and I sent all of the CSF leak patients to the sleep lab to get a sleep test. And we found that 83% of our CSF leak patients had obstructive sleep apnea. So it's almost a guarantee that when they come in with a leak that they're going to have sleep apnea. This is clearly far above the national average for the United States. And so if OSA is so prevalent in these patients, does it itself lead to skull thinning? So this is kind of a tricky question that we wanted to answer. And so we set up a study where at Indiana University, we looked at our sleep center database. And amazingly, they had 24,000 patients who've had a sleep study in the last 7 years. And so what we did was we searched the medical records to see if any patient who had a sleep study also had a high resolution CT scan of their head. And that left us with about 1,000 patients. So we didn't get any new scans, we just looked in the chart. And we excluded a few based on age and based on having a moderate sleep apnea scale. And then what we did was we matched cohorts, one with no sleep apnea and a CT scan, and another group with severe sleep apnea and a CT scan, and performed the skull measurements. And you can see that these are pretty well matched. They're both around 50 years old. BMIs are pretty similar, and their A1C for diabetes levels were pretty similar. And this time, we used a slightly different measuring algorithm. And this is an algorithm that you can get online through the NIH, National Institute of Health in the United States. You can download it. It's called 3D Slicer. And this can give you exactly the same as I did before, which is the measurement of the Hounsfield units of the skull that you highlight. And then you can get accurate volume measurements. And in fact, we looked at two different measured people. Like, so if let's say a medical student measures it and a resident measures it, how closely correlated are those two measurements? And you can see that the interclass correlation is very accurate when using this program. And this is a highlighted region of the skull we would measure on both sides. And this is the three-dimensional reconstruction of what we would be measuring of the calvarium. And we'd also measure the zygoma, just like we did in the previous studies. And so these are the results. So what we found was that, again, non-OSA patients versus our CSF leak patients have very thin skulls. But not surprisingly, the obstructive sleep apnea patients fall right in the middle. So they have thinning too, but they're not as thin as the CSF leak patients, suggesting that they're kind of on the path to becoming ultimately a leak patient. And again, the zygoma was completely the same. So this shows that obstructive sleep apnea independently thins the skull and skull base, okay? In the skull base, we also measured here, we measured the height of the intra-auditory canal, what we termed the skull base, and found that the skull base was also thinner, and the dehiscence rate of the tegmen was also twice as high. So this leads us to say that obesity is associated with sleep apnea, and we can find evidence to show that sleep apnea directly causes skull thinning and contributes to spontaneous CSF leaks. So next, let's look at intracranial pressure. So we performed a very similar study, looked at patients that had an accurate measurement of the intracranial pressure by lumbar puncture, and also had a CT scan in the chart. And we looked at those patients with normal ICP and those with elevated ICP. And this is a different way to present the data, but what it shows is that the black dots in the line is those patients with an opening pressure of greater than 25, which is consistent with intracranial hypertension. And if you correlate it with age on this axis here, the calvarial thickness decreases with age in patients with intracranial hypertension. Whereas normally, we see that patients that have normal pressure, their skull actually thickens with age. And this has been corroborated. And this, we did all of these separate patients based on race and based on age. And we can show that the calvarium across the board thickens with age, which is kind of unusual. We think it's because there's some loss of the cortex of the brain, so the pressure decreases as we get older. And so then that pressure decreases, so the skull actually thickens. And this is the opposite of what happens with the zygoma, the cheekbone. Consistent with osteoporosis, our cheekbone actually thins out with age. And so just like your femur and other bones of the body, the zygoma thins with time. So what this previous slide was showing is that elevated intracranial pressure actually reverses that thickening process. and leads to skull thinning over time. So now we can say that obesity is associated with these two problems that cause intracranial pressure, and intracranial hypertension and sleep apnea both are shown to cause skull thinning and skull base thinning, which ultimately lead to CSF leaks. So clearly we have to think about all of these conditions, these obesity-associated comorbid conditions, when we're evaluating and treating these patients. So I'll leave some time for questions. Hopefully you have things I can clarify. But spontaneous leaks are increasing in the United States. I think the MCF surgical repair is highly effective, safe, and leads to excellent hearing outcomes. And I would recommend that all patients with a spontaneous leak get a sleep study. I also offer them a lumbar puncture to check the intracranial pressure after the leak has been repaired. But unfortunately, a lot of patients don't take me up on that offer because it appears to be more invasive than the sleep study. And I think I've shown that obstructive sleep apnea and intracranial hypertension both lead to skull thinning, which contributes to the development of a spontaneous leak. And I think this is going to become an increasing part of our practice as neurotologists and as rhinologists with the anterior skull base leaks. We're seeing more and more of them. And so, again, I coined this term obesity leak epidemic. I hope this algorithm can kind of make some sense for you as far as what we think is happening as far as the pathophysiology. And then obviously I couldn't do this without a tremendous amount of help. So these are all of the researchers in the group. They include medical students, residents, faculty, the sleep center director, Dr. Manchanda, my colleague, Dr. Yates, who's another neurotologist. So it takes a lot of these very talented people to do this work. So I'll stop there and I'll take any questions that you have.
Thank you very, very much, Dr. Nelson. Very, very interesting talk. You know, the issue of obesity, of course, is not special to the United States. Actually, I think we hold in the UAE, we hold either number 1 or number 2 in terms of the rate of the obesity. So let's say, you know, I just had a few, you know, if anybody has a question, there's 2 questions on the chat line, but if you have any other questions, please go to the chat line. And if you want to speak to Dr. Nelson directly, please wave your hand and I will be happy to open up your microphone.
And I'll also bring it back to the first page. You can have my email.
Yeah, that would be great. Thank you.
Let me just close out of this. Yeah, just go back here. Okay, there you go. So this is my email. If you want to email me, be happy to take questions there too, but got plenty of time, so I'm happy to answer them now.
So let's say that somebody took you on your offer of measuring the pressure, and you do have elevated pressure. What would be your next step?
So it kind of depends on the pressure measurement. So if it's 25, I would say those people could probably be attempted to be managed with acetazolamide and aggressive weight loss management. For example, even getting them to bariatric surgery. An ophthalmologic evaluation is definitely something we do to make sure they don't have vision harming papilledema. If the patient has a pressure over 40, then I'm going to make a referral to the neurosurgeon to seriously consider a VP shunt, because those are the patients I think probably would not be well managed with acetazolamide. So I think those, that's kind of how I manage it.
Would you ever consider, you know, before actually doing surgery and closing the leak, ask the patient to address the weight issue? with bariatric surgery or other ways?
Yeah, so I think the timing of the surgery and the timing of the treatment of the comorbid conditions can vary. As we know, people tend to not do very well with weight loss. It takes a long time. And so my fear is that if I give them 6 months to a year with an open ear to the brain, they are at risk of having meningitis. So my preference is to repair it first and then get them to treat their comorbid conditions.
And what do you think in terms of like? I mean, I would think the same issues that has brought in the dehiscence of the tegmen could bring in dehiscence also in the ethmoid air cells and stuff. Have you do you ever get into that, or are you basically just focused on the being a neurologist and
Yeah, so recently we just, with my sinus colleagues, we measured the skull of patients with anterior leaks, and they have a very similar finding of skull thinning. They're actively setting up a prospective study to look at sleep apnea and intracranial pressure incidences. I think that's been published as far as ICP rates and anterior skull base leaks. So I think the pathophysiology is quite similar. What I think is interesting, though, is that if you think of like a Venn diagram of lateral leaks and anterior leaks, you would think that if there's skull thinning in both patients, a high incidence of them should have both lateral and anterior leaks, when in fact, the number of patients that overlap is quite small. So there's less than 10% of my patients have an active anterior leak while they have a lateral leak. So that's also kind of peculiar too.
Right. Can I ask you to take a look at the chat lines? There's quite a few questions. Maybe you could read through them.
Yeah, so let's, what is the layer of sheet and inner layer of the fascia and outer of the dural graft? Yeah, so I use multi-layer closure with fascia and then Duragen and Dura-Repair. The Dura-Repair is the sheet-like material. They're both collagen-based, synthetic, sort of, you get them out of a box sort of thing. So the only autologous thing is the fascia. And yes, so beta-2 transferrin, I use if there's any suspicion for, or if I'm concerned that I'm not accurate on the diagnosis. I don't give beta-2 on everyone. I don't think it's necessary. If they fit the criteria of a big tegmen defect, they're obese, and they have clear fluid coming out of their ear. Though the beta-2 is most valuable, in my opinion, for those patients where it's not clear cut. A thinner patient, tegmen defect's not super big, but they have this fluid that keeps coming out of their ear. Then I would test them with the beta-2. Before doing tympanostomy, how do you find out if they have a CSF leak? So I think the question is if I don't do an ear tube, how do I figure out if it's a CSF leak? Again, it's based on looking in the ear. It's not serous fluid. It's not yellow. It's totally clear. It's pulsating. And there's, I may even do a diagnostic myringotomy. But if there's a big tegmen defect and they're obese, then to me, that's a CSF leak. Yeah, subtotal petrectomy. Good question. Those would be in patients where the ear has no hearing, would be a great indication if they have a leak. You could argue that some patients that are older that may not tolerate the craniotomy would be better candidates for subtotal petrectomy or some type of procedure like that, but mainly it depends on the hearing status. Obesity leads to bone dehiscence, but is there any correlation between obesity and the dural dehiscence? Otherwise, what is the physiopathology of the dural dehiscence? Yeah, so I think obesity causes the comorbid conditions of sleep apnea and intracranial hypertension. Obesity alone does not cause the leak. So the comorbid conditions cause the skull thinning and the defects in the bone. And it's likely that as we age, we know there's thinning of the dura, and also the continual pulsation of the brain against the bone defect causes the tears. That's my thought. What about studies on spontaneous leaks in anterior? Yeah, we talked about that. How long do you wait to repair CSF leaks in case of presentation with meningitis? Do I repair both with bilateral? So meningitis, good question. So I've done it two different ways. I have repaired them in the active setting of meningitis. I've done one or two patients that way that are very, very sick. If they're recovering, I usually want to wait and give them IV antibiotics, and then have them come back to clinic, talk about all the risks and the issues with the surgery, make sure they're comfortable with that, and then proceed with the surgery approximately 6 weeks later. Bilateral, I never do at the same time. I always do one, let them recover.
Hello? Hello? Somehow we had a disconnection, but I think we're basically coming to the end. So thank you. If you can hear me, Dr. Nelson, thank you very, very much for being with us. This is a great lecture. I just want to share with you this slideshow. Basically, what I want to we got an app done, and this app would basically keep up. You could keep up with the program. You could get it on your mobile phone. You could get notifications and update your calendar. So if you are, if you're reaching us through the computer, you could take a picture of the QR code, and you could follow follow the link to download the app. And if you are using mobile and you're reaching us through the mobile, what I will do for you is that I will give you a link on the chat line, and that link you could follow on your mobile, and you can download the app. Here we go. So again, this I think would make it easier for you, to allow us also to communicate, allow us to send you messages in case we have any updates on the program. And it will continuously update the program for everybody. So again, thank you all, and it's nice seeing you again, and hopefully we'll see you tomorrow for Dr. Anil Aroni's lecture. Thank you, and have a nice evening.